Hutchison, and I'm a consultant radiologist and also the Director of Breast Screening for the Manchester Screening Programme. I'm going to talk to you today about breast screening so that hopefully it can facilitate some easier conversations with your patients if they approach you about whether they should undertake breast screening or not. Of course, the aims of breast screening are to detect the breast cancer earlier so we could facilitate some less invasive treatments for ladies and improve the prognosis for them and ultimately save lives. We will send a standard invitation to all ladies between the ages of 50 and 70 who are registered with a GP. And depending on when the GP's practice is due to be screened, a lady will receive her first invite between the age of 50 and 53, and thereafter be invited for mammography every 3 years. Once ladies reach their 71st birthday, they will no longer be routinely invited, but they are perfectly welcome to self-refer for breast screening every 3 years. They can contact the breast screening office themselves, or they may ask you as their GP to contact the breast screening office on their behalf. We also screen the increased risk women, and these are women who are at a very high risk of breast cancer because of gene errors or because they've had supradiaphragmatic radiotherapy at an earlier age. They're screened under the breast screening programme and they have annual screening, and sometimes we use additional methods such as breast MR. We don't routinely screen women under the age of 50 unless they're very high risk, because breast cancer is less common in younger women, and also mammography is less sensitive due to breasts being denser and therefore obscuring the early signs of breast cancer. What happens when a lady is invited for screening? She gets an information leaflet entitled Helping Her Decide, and she can phone and telephone the screening unit to book a convenient appointment. When she attends the site, and this may be a static site or it might be a mobile screening van which is in the area of her GP's practice, she'll be seen by a female mammographer. All mammographers in the breast screening programme are female. They'll provide the lady with an explanation of what's going to happen, and they'll also take a brief breast history from her. She'll be asked to undress to the waist, and she will have been asked to avoid deodorant or talc on that day because the deodorant or talc can show signs on the mammogram which may mimic early breast cancer. 4 views will be done, 2 of each breast, and once the screening has been done, the mammograms are read independently by 2 readers. They will decide whether there are any signs of breast cancer that require recalling to the assessment clinic, and a final decision is made after a consensus meeting between both the readers or sometimes 2 independent readers, and this process takes around 2 weeks. When the lady receives her letter, about 96% of women will receive a normal letter within the 2 weeks, and they will simply be invited for breast screening again in 3 years' time. But around 4% will be recalled for a possible abnormality, and they will receive an assessment clinic appointment. Occasionally, it's necessary to recall women because of a technical problem with the mammogram. It might be blurred or have artifact on it or so on, and the women will be called to the same site as previously and simply have that view repeated. Sometimes women will tell us they have symptoms when they come for their breast screening, and they may have not seen their GP because they knew they were about to have a breast screening mammogram. So if a woman reports something like a lump or a bloodstained nipple discharge, even if her mammogram is normal, we will recall her to the assessment clinic for further evaluation. When she comes to the assessment clinic, a lady will be given an explanation of why she's been recalled, and she'll be offered the support of a breast care nurse. She'll undergo a clinical examination, and she'll have some further mammographic views where necessary, and also an ultrasound of the breast and sometimes also of the axilla. If, as in the majority of cases, this is all normal, and a second assessor also agrees that it's normal, she'll be reassured and she will be discharged and sent a further invitation in 3 years' time. If there is an abnormality confirmed, then we would attempt to biopsy the abnormality at the same visit, and this will be under mammographic or ultrasound guidance, and the results will be available within about 5 working days. So your patient might want to know, should they go for breast screening? As we've said, lives can be saved because breast cancers are found and treated earlier. 99% of women diagnosed with early stage breast cancer will survive for 5 years. And about 70% of screen detected breast cancers are small enough that we can use breast conservation techniques and more minimally invasive surgery, reducing the morbidity for ladies. Similarly, about 75% of invasive cancers found at screening are node negative, which means we may not need to use as many adjuvant treatments for these ladies, and again, reducing the morbidity associated with breast cancer treatment. The risks of breast screening are that a patient may undergo undue anxiety due to being recalled for further investigations, which then don't find cancer. Screening can also miss cancers and provide false reassurance, and women are advised that if they do develop any symptoms, even very recently after breast screening, they should still attend for medical attention. Of course, not all cancers found by screening can be cured, and we may be informing a patient they have a cancer we can't cure them from, but hopefully we still reduce the morbidity associated with that cancer. And not all cancers found by screening would have affected the women in her lifetime. So some of the very small, low-grade cancers may not have caused any problems for that lady throughout the rest of her natural life. Mammography can be a little uncomfortable or sometimes painful, and it does involve a small radiation dose, but this is felt to be negligible when carried out in the 3-yearly intervals that we carry out breast screening. And also, the lady can take ibuprofen or paracetamol about an hour before a mammogram if she does find it an uncomfortable process, and that certainly helps. A patient might want to know if they can have breast screening for a variety of other reasons. They may have breast implants in place. And yes, we can screen ladies with breast implants. We perform some additional views, and we also reduce the amount of compression. It's helpful if the patients can inform us that they have breast implants so we can adapt our techniques. Similarly, if patients have a pacemaker, they can have breast screening. The pacemaker is not affected by the X-ray radiation. We use slightly less compression, and we see most of the breast tissue, just a little bit will be obscured by the pacemaker. If a patient is transgender and they're a trans woman registered as female in their GP practice, they will be routinely invited for breast screening. Trans men will be registered as male generally, so they will not be routinely invited. But if they've had breast surgery, they have the potential for breast tissue to remain. So they can contact their local breast screening office to arrange their own breast screening, and we will certainly accommodate that. If people have physical or learning disabilities, we will accommodate them more often at our static sites because it's generally more accessible. We would like to be informed in advance, if possible, of their additional needs so that we can encourage these people to attend for screening and can adapt our processes to help them make it as easy as possible. It's unusual for us to have ladies who are pregnant or breastfeeding within the normal breast screening age range of 50 to 70, but in our high risk younger women, we do come across this. The actual dose of radiation from a mammogram is fairly negligible during pregnancy, but it's more the differences in the breast tissue because of pregnancy, and particularly when breastfeeding, that make it difficult for us to detect breast cancers. So we would delay screening until 3 months after breastfeeding had stopped. And again, it's just helpful if ladies can inform the unit so we can just put a pause on their breast screening for the time being. If a lady has been under breast cancer care already, or maybe had a recent symptom and attended the breast unit, they may have had a mammogram recently. We wouldn't perform a breast screening mammogram if a patient has had a mammogram within the last 6 months. So again, they only need to inform us as the unit, and we'll postpone their breast screening and send an invitation out in 3 years' time again. So in summary, we will invite ladies for breast screening between the ages of 50 and 70 every 3 years. We can accommodate implants, pacemakers, disabilities. We want to make the service as accessible to everybody as possible. 4 women in about 100 will be recalled, and 1 will be diagnosed with cancer. And we've looked through the pros and cons of breast screening, and ultimately the patient needs to make an informed decision. Hopefully this talk will enable you to have an informed conversation with the ladies should they approach you about aspects of breast screening. And further information can be found on the .gov website, where there's a lot of helpful information, including this link to helping you decide. Thank you very much.